Now moving on, I would like to introduce our next speaker, Dr. Laquisa Hill. Dr. Hill completed her medical school from University of Texas, Galveston, and her residency from Vanderbilt University. She went on to do a clinical fellowship in hematology-oncology at the MD Anderson Cancer Center and subsequently joined the Houston Methodist Baylor Cell and Gene Therapy Unit. Today, she will be talking to us about the role of stem cell transplants in myeloproliferative neoplasms. Dr. Hill.
My name is Laquisa Hill, and I'm one of the BMT attendings in the Center for Cell and Gene Therapy at Baylor College of Medicine in Houston Methodist Hospital. And today, my talk will focus on indications for allogeneic stem cell transplant in patients with myelofibrosis. Here are my disclosures, and here are the objectives I will cover over the course of the talk. So despite the availability of JAK inhibitors for the treatment of myelofibrosis, allogeneic stem cell transplant remains the only curative therapy for both primary and secondary myelofibrosis. And while the efficiency or efficacy of allogeneic transplant results from high-dose conditioning chemotherapy in addition to graft versus tumor effect following allogeneic immune reconstitution, the procedure is associated with significant morbidity and mortality due to regimen-related toxicities, graft rejection or failure, graft versus host disease, and high risk of infectious complications. The need for transplant is often questioned both by patients and providers now that quote-unquote less risky therapies such as JAK inhibitors are now more widely available. While there is a lack of consensus and heterogeneity of data on various aspects of stem cell transplant for the treatment of myelofibrosis, such as the role of age, best graft source, and conditioning regimen, this has led to continued controversy in the selection of patients best suited for stem cell transplant. Ruxolitinib, as you all know, was the first JAK inhibitor approved for myelofibrosis in 2011, and in August of 2019, fedratinib, a JAK2 selective inhibitor, was approved. And while JAK inhibitors may provide significant improvement in splenomegaly, constitutional symptoms, and quality of life measures, they do not modify the underlying disease course or provide curative therapy. Reduction in the JAK2 allele burden is only modest at best and does not appear, and JAK inhibitors do not appear to reduce the risk of leukemic transformation. Long-term data has shown that approximately 50% of patients will discontinue ruxolitinib on average of 2.5 to 3 years due to loss of response and/or side effects. Others, such as those with multiple mutations or unfavorable cytogenetic karyotype, may have an inferior response to JAK inhibitor treatment and therefore a much shorter time to treatment failure. It remains unclear if the favorable response related to JAK inhibitors leads to better transplant outcomes because patients who respond to JAK inhibitors have an intrinsically more favorable biology, or because JAK inhibitors improve the clinical status of patients, allowing them to proceed to transplant. In this slide here, we have data from the Center for International Blood and Marrow Transplant, or CIBMTR, which shows trends for transplant in myelofibrosis between the years 2000 and 2014. Diagram A represents the number of transplants that were carried out each year during this time frame, and as you can see, despite the approval of Jakafi in 2011, the number of transplants has actually increased, unlike when TKIs were approved for the treatment of CML and the use of transplants drastically decreased. And in diagram C, we observe that the number of transplants in patients greater than 60 years of age, which is represented in the blue portion of the bar, and the percent of transplants using unrelated donors has also continued to increase over time, which may be influenced by the adoption of reduced intensity conditioning, which has allowed a larger proportion of older patients with myelofibrosis to be considered for allotransplant. As I'm sure you are all well aware, there are multiple prognostic scoring systems that have been developed with the primary aim to determine which patients with myelofibrosis should be referred for transplantation. In general, patients with intermediate risk 2 and high risk disease who have a median overall survival of less than or equal to 5 years or greater than 20% risk of leukemic transformation over 5 years should be referred for consideration of allotransplant. Of note, all of these scoring systems were based on studies done in patients with primary myelofibrosis only and were also developed prior to the wider availability of JAK inhibitors. In contrast, low and intermediate 1 risk patients are not routinely offered transplant. However, patients with intermediate risk 1 disease who have transfusion dependence or unfavorable cytogenetics, especially if younger, should be considered for allotransplant. And while there is no consensus regarding the optimal prognostic tool to use, in general, models that incorporate both cytogenetic and molecular features are more discriminatory in distinguishing these risk groups than those that use clinical features alone. If both cytogenetic and molecular data is available, then GIPS is a simple tool used to determine those patients that fall in both either the highest or lowest risk of death. For those falling into an intermediate risk category based on GIPS scoring, the MIPS 70 plus version 2 can be used to further stratify those patients to determine what patients might ultimately benefit from transplant. However, each center and physician has their own preference and may prefer using MIPS 70 up front. And if no molecular analysis or cytogenetic information is available, then the DIPS plus scoring can be used. Recently, the myelofibrosis secondary to PV and ET prognostic model was introduced to assess prognosis in patients with secondary myelofibrosis and has been validated in both EBMT and Spanish registries in patients with secondary myelofibrosis. However, this has not yet been incorporated into standard practice among most transplant centers. And whether or not this will translate into better overall survival in patients with secondary myelofibrosis undergoing transplant will require for further studies. Meanwhile, it may serve as an additional prognostic tool to base the indication for allotransplant in this subgroup of patients. Tafari et al. Have also recently shown in a retrospective study that allogeneic transplant can overcome adverse survival effects from very high risk and unfavorable karyotypes in myelofibrosis. In the unstratified analysis, denoted in diagram A, the median survival was 9.3 years in patients who underwent transplant versus 3 years in those who did not proceed to transplant. And in a comparison of post-transplant survival in 56 patients who were compared with a control group of 56 patients with primary myelofibrosis stringently matched for age, DIPS score, and cytogenetic risk category, patients with intermediate risk 1, 2, and high risk disease, or those with very high risk or unfavorable cytogenetics who underwent transplant, which are these lines demonstrated as dotted lines, had significantly better overall survival compared to those who did not ultimately proceed to transplant. So early referral remains the critical factor for optimal transplant outcomes, as delays in referral can reduce success rates for transplant, as there may be a narrow window of opportunity, particularly for those with higher risk disease, to proceed to transplant. And delays might preclude the ability for patients to undergo transplant altogether. Here are patients that should be considered at the time of diagnosis: those with DIPS intermediate 2 and high-risk disease, those with DIPS intermediate 1, with low platelet counts, transfusion dependency or complex cytogenetics, or patients who have any of the following high-risk non-driver mutations, or those with triple-negative disease. If allogeneic transplant is a possibility, HLA typing should be pursued upfront and potential donors identified at the time of diagnosis, whether or not the patient proceeds immediately. So careful review of patients' disease and transplant-related factors is required in the appropriate selection of patients who are eligible for transplant. There are no prospective randomized trials comparing transplant to non-transplant therapies to further guide clinical decision-making, but based on available data, we know that JAK inhibitors do not modify the disease course, although multiple other agents are currently undergoing clinical investigation. Patients who have non-CALR driver mutations, significant cytopenias, high-risk cytogenetics, non-driver mutations or subclonal mutations, are patients with increasing peripheral blasts or leukemic transformation, are at risk for significantly shortened survival if they do not proceed to allotransplant. On the converse side, patients who are older individuals and thus more likely to have comorbidities, which may create challenges even when using reduced intensity conditioning regimens, may suffer worse outcomes after proceeding with transplant. Lack of a suitable donor is also an important concern, as studies have shown that patients who undergo mismatch unrelated donor transplant have increased non-relapse mortality and decreased survival. And patients with severe portal or pulmonary hypertension are also at increased risk of higher non-relapse mortality due to regimen-related hepatotoxicity or respiratory failure. I would also like to point out that insurance coverage also plays an important role in patients who are able to proceed to transplant, as myelofibrosis is not currently an indication for transplant under the National Coverage Determination, and therefore is not covered under Medicare insurance, which presents a huge barrier of access for older transplants seeking consideration for allotransplant. While post-transplantation hematological recovery has regularly been reported in splenectomized patients, along with better graft function, the influence of splenectomy on post-transplantation survival or relapse is more controversial, thus giving the not insignificant periop morbidity of 25 to 30% and a mortality rate of 6 to 7%. Use of splenectomy is not routinely recommended. However, it may be considered on a case-by-case basis, particularly in patients with a significant spleen burden or significant pain and constitutional symptoms related to the enlarged spleen. So optimal timing of transplant is based on individual patient and transplant specific factors, which have to be carefully considered in each patient who is evaluated. Also taking into consideration the patient's goals of care and desire for quality of life. But in general, the aim is to proceed to transplant as soon as a donor is identified if the patient is otherwise eligible. Delay in therapy, which leads to progression of disease or leukemic transformation, is associated with very poor outcomes, and patients with blast transformation do significantly worse with transplant and are not generally considered eligible. However, if they receive induction therapy or debulking therapy and achieve a good response or remission, they may be later considered for transplant. And in patients who are responding to JAK inhibition, while there are no prospective studies addressing the question of what time point patients should proceed to transplant, there has been a large retrospective study evaluating patients who underwent transplant between 2009 and 2014. And in this study, they showed that in patients who were responding to Jakafi prior to transplant, the 2-year overall survival was 90% versus 55% in those patients who had stable disease or worsening splenomegaly, development of constitutional symptoms, compared to 32% in patients who actually had leukemic transformation. Response to Jakafi was also, pre-transplant was also associated with a lower 2-year non-relapse mortality. And so while one must be cautious in drawing any strong conclusions from this study due to the retrospective nature and the potential risk of selection bias, these data do raise an important question that I mentioned earlier regarding whether better outcomes in these patients is related to clinical improvement prior to transplant from use of JAK inhibitors, or is it a result of a direct effect of JAK inhibitors, or does it just select for patients who have a more favorable disease biology? Another important consideration in patients who are receiving ruxolitinib pre-transplant is the timing of discontinuation. And so, as we all know, that abrupt cessation of Jakafi can be associated with significant and even life-threatening withdrawal syndrome. And so typically we initiate taper within 5 to 7 days prior to the start of conditioning in an attempt to prevent complications from withdrawal syndrome. And this chart here is just a picture of a suggested taper based on a study done by Gupta et al. However, the discussion and timing of taper should always happen in collaboration with the transplant provider to prevent unnecessary toxicity and potential delay of the patient proceeding to transplant. So what is the best donor and conditioning regimen? Well, there is no one best answer, and there's no consensus regarding the optimal source of stem cell graft or choice of conditioning regimen. And the approach varies by institution and by transplant physician. Peripheral blood currently is the most used source of hematopoietic stem cells for both match-related donor and unrelated donor transplants. And while alternative donor sources have been shown to have some efficacy, the true success rates and incidence of complications such as graft failure and graft versus host disease remain to be determined. In terms of the use of reduced intensity versus myeloablative conditioning, the results are variable, but overall seem to be comparable. And so generally myeloablative conditioning can be offered to fit patients who are less than age 60 to 65 years old. Here I've listed several studies in descending order from time of performance, with most recent studies listed on the top, with the exception of the last study, which I'll mention in just a second. And as you can see, most studies included patients who received both reduced intensity and myeloablative conditioning, with a median age of patients being in the mid-50s. In the three most recent studies listed at the top, they primarily use reduced intensity conditioning, and after 3 to 5 years of follow-up, you can see that the overall survival at 5 years ranged 47 to 65%, with the non-relapse mortality of 16 to 24%, in comparison to some of the older studies where 5-year overall survival was 30 to 55%, with a non-relapse mortality of 30 to 50%. And these outcomes were in all comers, not stratified by donor type or conditioning intensity. And the last study here by Samuelson et al. Specifically looked at patients aged 60 to 78 with a median age of 65 who underwent match-related donor or unrelated donor transplant using a variety of conditioning regimens. And the 3-year overall survival was 45%, with a non-relapse mortality of 30%. And while these patients were probably so highly biased and selected, the results were encouraging that showed that older patients who were fit and in good condition should be considered for allotransplant. So looking at slightly more recent data on transplant outcomes for myelofibrosis, this is, again, data from the CIBMTR. And on the left-hand side, or your right-hand side, we have patients who underwent match-related sibling donor transplant between the years 2007 and 2017. It was roughly a total of 1,900 patients, which included both myelofibrosis and secondary myelofibrosis due to ET or PV. And in the subsequent chart, we see outcomes for patients who underwent unrelated donor transplants. And the 3-year probability of survival in patients undergoing match-related donor transplant was roughly 61% for myelofibrosis, and in the unrelated donor arm, essentially comparable at a 3-year survival of 55%. And then looking in the overall trends over time, you can see here that in each of these time frames, with the most recent being 2011 to 2017, the 3-year survival in patients with MPNs has continued to slowly improve over time. And so, do mutations matter for transplantation outcomes? We know they matter for upfront outcomes at initial diagnosis. And so several groups have attempted to evaluate the impact of mutations on the outcomes of transplant. A study by Kroger et al. Retrospectively evaluated 169 patients who underwent transplant with busulfan conditioning, and the results showed that presence of CALR mutation was associated with favorable overall survival and non-relapse mortality, while AXL1 and IDH2 were independent prognostic risk factors for decreased progression-free survival. Ali et al. Evaluated the outcomes of patients who underwent reduced intensity conditioning with flu-mel and looked at a variety of somatic mutations, including AXL1, EZH2, IDH1, 2, SRSF2, and UTAF1, and noted that patients who had UTAF1 had increased non-relapse mortality, although CALR, AXL1, and IDH1 and 2 mutations were not found to have any significant impact. And in a study of roughly 100 patients evaluated by Tamari et al., these findings also showed that there was no impact on overall survival or relapse-free survival for patients with AXL1, SRS2, IDH 1 or 2, or EZH2. And so while these findings further support the use of targeted gene panels to determine mutational risk profiles, larger prospective studies are needed to fully validate these findings. This slide here essentially just is an example looking at a new prognostic scoring system known as Myelofibrosis Transplant Scoring System, which was developed in an effort to try and better predict outcomes following transplant and assisting with counseling regarding post-transplant prognosis. And in this analysis, there were both patients with primary and secondary myelofibrosis included. 7 individual independent risk factors were identified, including age over 57, KPS less than 90, non-CALR, MPL driver mutations, AXL1 mutation, use of an unrelated mismatched donor, and elevated white blood cell count or low platelets prior to transplantation. And they were able to use these risk factors to define 4 levels of risk stratification ranging from low to high, with 5-year survival risk by risk group of 83% in the low risk, 64% in the intermediate, 37% in the high risk, and 22% in the very high risk group. And so while additional validation is required, this score system is an additional tool to help with clinical decision making for patients who are eligible for transplant and maybe on the fence about whether or not to proceed. And this study here is really a retrospective multicenter analysis that looked at disease and treatment-related factors to assess association and survival differences based on transplant data obtained from the CIBMTR between 2000 and 2014. And non-transplant data was obtained from the MPN Research Consortium. And what I would really like to point out in this graph here is that while there was early dropout in the transplant group, primarily due to transplant-related mortality, and the curves crossed much later in the clinical course, several years out, up to 5 years out, the slope of the curves start to change much earlier, around 1 year following transplant, and then plateau, indicating that the overall survival benefit with transplant actually begins much earlier than when the curves actually cross. And long-term survival advantage with transplant was observed for patients who had intermediate 1 or higher risk disease, although potentially at the cost of higher early mortality. And the magnitude of this overall survival benefit increased as the DIPS risk score increased. And so this study just further highlights the need for, again, careful patient assessment and risk-benefit discussions with patients regarding transplant versus non-transplant options, as well as continued development, the need for continued development aimed at therapies or interventions to reduce post-transplant complications. So just briefly mentioning some of the transplant complications that can occur due to splenomegaly and portal hypertension or extramedullary hematopoiesis in the liver. These patients can be at high risk for liver injury. If they have pulmonary hypertension, potentially at increased risk of respiratory failure during the course of the transplant. Graft failure or poor graft function is a potential complication. And as I mentioned earlier, potentially higher risk of this in patients who have a significantly enlarged spleens, but the reported incidence varies anywhere from 2 to 25%, and also depends on the conditioning regimen and cell source. Infection is a risk for all patients, not just myelofibrosis patients undergoing transplant. And of course, graft versus host disease and relapse are the primary causes of non-relapse mortality. So issues remaining to be addressed are questions that still are unanswered, include administration of JAK inhibitors throughout treatment, including use post-transplant, the use of Jakafi after transplant for persistent splenomegaly, the timing of transplant for responders to JAK inhibitors, and in patients failing to respond, should they proceed directly to transplant after lack of response in the first few months, or should other investigational agents be tried? And again, the timing of proceeding to transplant as soon as a donor is identified, should that happen even in patients that are responding to JAK inhibitors. And so just a few key points. Allogeneic transplant is associated with prolonged survival and potential of cure in the appropriate patients, particularly those who have high-risk disease. The transplant referral should occur early after diagnosis, both to assess suitability and to determine donor options. And patients should be repeatedly seen or assessed during the course of disease, because those who may not have been eligible initially may become candidates over time. Age should not be a hard stop or barrier for referral. And patients with intermediate 1 risk disease who have high-risk features such as transfusion dependence, increasing peripheral blast, or adverse cytogenetics or karyotype should be referred for evaluation as well. Overall, the use of JAK inhibitors pre-transplant is safe and should be used in patients that are symptomatic prior to proceeding to transplant. And if at all possible, the mutational status should be determined to further help refine the risk of patients that are considering proceeding to transplant, or even to determine the indication for transplant. And in general, additional studies are needed, not only to find better agents to treat myelofibrosis, but also to address many of the controversial issues surrounding transplant in terms of best conditioning regimen, best GVHD prophylaxis, and also addressing ways to improve non-relapse mortality and relapse following transplant. Thank you for your time and attention, and I'll take any questions at this time.
There's a question that came in. Is there a role for CAR T-cell therapy in myelofibrosis patients?
Okay. So great question, but at this time, there's currently not any, certainly not any clinical trials I'm aware of using CAR T-cell therapy. There may or may not be some basic science research going on in the area, but I think the primary issue would be identifying a potential target antigen, which I am not aware of. So at this time, unfortunately, no, there's no options as far as CAR T-cell therapy for myelofibrosis.
Thank you. Thank you, Dr. Hill.